Dear children, I am Dr. Anil Kumar Jain. I am professor and head of orthopedics at Santosh Medical College and Santosh deemed to be University, Ghaziabad. Well, I am presenting today a topic which is very common to us all, and it's very common to Indian subcontinent, and that is the tuberculosis of spine. Now, if you go to the history of spinal tuberculosis, although tuberculosis has lived in symbiosis with human being since time immemorial, and the proof is that in the Egyptian mummies it has been found, which were mummies which are almost 4,000 years old. So, but then this disease was identified and described first by Percival Pott somewhere between 1779 to 1792, and he described it as a painful kyphotic deformity of spine associated with paraplegia. Means he identified that a paralysis of the lower limb with the increased concavity of dorsal spine and deformity of the spine. So he described it as a kind of palsy with spinal deformity. Now, in the present time, 1/5 of the world TB cases are in India, and out of all cases, 2 to 3% are bone TB, and out of these 2 to 3% bone TB, 50% are spinal TB, and out of all 50% spinal TB, 50% occur in children. We have over 2 million active spinal TB cases at any given time. Now, it is common to all ages. It can occur in any part of the spine, from cervical spine to dorsal to lumbar to sacral, and any part of the body, whether it is vertebral body or posterior complex, can be affected, but then most common is vertebral body. Now, well, I am talking about bone TB, but when we talk about predisposing factor, then it is, since it is an extrapulmonary disease, the first lesion occurs in lung, and that is why all those children who are malnutrited, they are more likely to have pulmonary TB, and they are more likely to have a bone and joint TB. Those persons who live in poor sanitation, those people who live in overcrowding, so with one pulmonary TB case is spreading to the other, and this close contact is one of the most common cause of spread of the disease. And anyone where immune system of the body is deficient, then the bone and joint TB lesions can occur more commonly. Now, as I said, the first lesion of tuberculosis occur in lung, and that is called primary spinal TB or pulmonary, and then the bone TB and spinal TB is always secondary. So once the pulmonary TB occur, as a result of hematogenous dissemination, bacteria reach these different bones. It reaches the spine by hematogenous route through the blood, and since the more chances of getting inoculated in spine is because the venous plexus, the veins of the paravertebral plexus called Watson's plexus, and they are valveless. Generally all veins in the body, they have a valve, but the venous system of the spinal column, it doesn't have a valve. So as a result of it, any increase intra-abdominal pressure pushes blood to the vertebral column, and as a result the lodgement of bacteria takes more in the spinal vertebral bone than the other bones. Now, once as a result of hematogenous dissemination, infection is lodged in bone and joint. Now, as a result to this infection, there is a polymorphonuclear infiltration all around, and these polymorphonuclear cells, they gets converted into monocytes and macrophages, which can do the phagocytosis. As a result of phagocytosis of bacteria, These are converted into epithelioid cells, and these many epithelioid cells fuse together to form a Langerhans giant cells, which is characteristic of a tubercular granuloma, and surrounded by a ring of lymphocytes. So that is how a tubercular granuloma forms, and this is what is tubercular granuloma, that in the center and then epithelioid cells and then the Langerhans giant cell and the rim of lymphocytes. Now this central part of granuloma undergo necrosis, liquefactions, and as a result the small amount of caseation and pus forms in the center of a granuloma. Now these small granuloma, multiple granuloma fuses, coalesces to produce a big granuloma, and thus this collection of pus becomes accentuates and it becomes an this pus collects underneath anywhere in the body as a cold abscess. Now if you look at the regional distribution, although any vertebral body is affected, but more common in dorsal spine, dorsolumbar junction, lumbar spine, cervical spine, sacral spine, in that order. Well, there may be more than one lesion with normal intervening vertebral bodies, and then it is described as a skip lesion. Now this is the regional distribution what I was talking about, that since it is more common in dorsal 42%, dorsolumbar 12, so almost 54% are in dorsal and dorsolumbar, cervical 12, lumbar 26, cervicodorsal 5%, and this is what is the regional distribution of a disease. Now when we talk about one lesion, then out of the, you could see this line diagram, these are vertebral body, pedicle, superior facets, inferior facets, transverse process, spinous process. So the most common is a paradiscal lesion, where a lesion occurs on both sides of a disc space, or the second is it may be just in the center of vertebral body and one vertebral body is being affected, or it may remain anterior underneath the anterior longitudinal ligament, or any part of the posterior appendiceal posterior complex is being affected. So these all four type of presentations, they are around 2%, while paradiscal is about 98%, where disc on both sides of the disc vertebral body is affected, that is 98%. Skip lesions, about roughly 7% of the spinal TB lesions, they have another lesion in the spine anywhere far away from the main lesion, and that is why skip lesion is about 7%. Now this is the diagrammatic representation, paradiscal lesion on both sides of disc spaces, central vertebral body lesion, anterior subligamentous disease or appendiceal or posterior complex disease, this is spinous process, or this is the pedicle disease. Now since we are talking about 98% paradiscal lesion, I'll just try to show you the pathology of a paradiscal lesion. Now this is a disc space, and as a result of disease, this both sides gets inflamed, and as a result of inflamed vertebral body, there is always a chelation, because whenever there is an increased blood supply to the bone, calcium is washed away, and as a result there occur an osteopenia. So this subchondral bone become weaker, and this disc starts herniating into the diseased inflamed vertebral body, and if this process continues and not diagnosed and not treated, this disc completely herniate into the diseased vertebral body above and below. Now as a result of loading of the vertebral column, since in a kyphotic dorsal spine is kyphotic, means concavity anteriorly, so line of weight transmissions, they are more anteriorly. As a result, anterior body height is lost, and gradually the patients develop a increased kyphosis and a kyphotic deformity. So if we talk, when we talk about pathogenesis, we take step 1, bacilli from primary focus through blood stream reach paradiscal area, then the infection spread to vertebral body and but above and below on both sides of the disc spaces, and then the bone weakened by the infection collapses under the weight of the human body. So this collapse leads to anterior height loss. Now these are two vertebral body, and this anterior height loss has occurred while posterior is a bigger height. So this means there is an accentuation of anterior concavity, that is kyphosis. Now the deformed vertebral column, this deformed bone and the diseased tissue, granulation tissue and pus breaks the posterior wall of the vertebral body and enters the spinal cord to produce indentation onto the spinal cord, a pressure onto the spinal cord to produce a neural deficit, that is weakness or paralysis. And that is what, that if this disease is left to the extent allowed it to progress, then this can produce a paraplegia. So over time the deformed vertebra heal, and now you start treatment. So this vertebral body will heal in the deformed position, and this may further, and this nerves coming out may continue to have a neuralgic pain or a neural deficit as a result of pressure onto the spinal cord. As I said, in a granuloma, pus forms. Now this pus from the diseased vertebral body spreads outside along the path of least resistance. So what is the path of least resistance? It collects under the anterior longitudinal ligament or open into a muscle as a psoas muscle, and then it collects into the psoas muscle, or this pus may travel along the neurovascular bundle. So at every level a nerve is coming out, so along this nerve the pus may travel outside. Now this pus from the vertebral column may present anywhere in the body, and anteriorly in cervical spine. If it spreads posteriorly, it can produce a posterior abscesses or anterior cervical abscesses. You could see this is sternocleidomastoid and a pus and a cold abscess lying in the triangle, cervical triangle. In a dorsal spine, it passes along the intercostal nerve and may present along the chest wall. In a dorsolumbar spine, it enters into the psoas muscle, and you could see here that this has entered into the psoas muscle. You could see this is the psoas muscle and produces psoas abscess. In lumbar spine, it may present in iliac fossa. This is a huge psoas muscle. These are the MRI of vertebral column, and you could see this is one psoas collection into the psoas muscle. This is another side psoas muscle, or may collect into the iliac fossa as a in the iliacus muscle and iliopsoas muscle as a iliac abscesses. Or you could see here in axial picture where you see the vertebrae, and this is the vertebrae and this is the psoas collection into the psoas muscle. Now this was all about pathology, but then when these patients present clinically, how do they present? Generally, when the inflammation starts, the patient starts experiencing pain, and this onset is always insidious, and very rarely it may be acute, but most of the time it is insidious, and this pain may radiate or pain may be with the activity, or it radiates if the nerve is irritated, then it may have a radiating pain. Now these patients, since tuberculosis is a infective, so these patients have a constitutional symptom as a reduction in the weight, mild fever, loss of appetite. So these kind of a constitutional symptom patients may experience it. Now when this inflammation starts in the spine, first thing that patient have a stiffness of the spine, and patient feels movement of the spine is painful. So patient says that I want to lie down, or I want to quietly sit down and not move, because on movement this pain is aggravated. Gradually, if it still remains diagnosed, then kyphotic deformity appears, and this and swelling, multiple swelling because of the presence of a cold abscess. Now when there is a pressure onto the spinal cord, then weakness starts appearing, that is the neural deficit. So you could see from early just pain alone and constitutional symptom and stiffness alone, progressing, remaining undiagnosed, ending into kyphotic deformity and a peripheral cold abscesses and pressure onto the spinal cord producing as a weakness. However, there are certain atypical lesions where these symptoms are less and what presents is a weakness, and those are called atypical presentation when it is primarily a intraspinal disease. So, in active stage, back pain is the commonest symptom. Presenting complaint, it may be a diffuse back pain or a radicular back pain. Presents as pain in the arm for cervical root, girdle for a dorsal root, abdomen, dorsal and lumbar root, groin, lumbar root, and sciatica as a lumbosacral root if there is a nerve irritation. Stiffness, very early symptom, and this is a protective mechanism of the body. See, whenever an inflamed organ, a part of the body, they have a shearing, then it produces pain. So, to stop that shearing as a result of movement of the body, the muscle undergoes spasm. So, muscle spasm is a protective mechanism of the body, and that is why when these patients, they sleep in the night, they sleep comfortably and suddenly get up with this severe pain. These children, they start shouting, and that is called as night cries. What does that mean? That now while the deep sleep, muscles undergo muscle spasm relaxes, and the vertebral body, they are allowed shearing motion of while turning into the bed, and the moment patient takes some turn, some twist while sleeping, the inflammation, the severe pain occurs and muscle spasm comes into the force, and that is what is called night cries. These cold abscesses, patient may present with swelling anywhere in the body. However, sometimes these abscesses have some compression effect. Say for example, if in upper cervical spine, if it collects just in front of vertebral body, the tracheal shadow and air column and oropharynx and nasopharynx, that gets pushed, and as a result patient experiences dysphagia, difficulty in eating, or patient may have breathless and hoarseness of voice because of the upper cervical spine involvement. If the cervicodorsal junction, the pus may collect underneath the in the upper dorsal spine in a mediastinum, and that may have a dysphagia. When it collects into the psoas muscle, patient may experience a flexion deformity of hip. Now, this spinal deformity generally occurs as a kyphotic deformity because the weight transmission causes loss of anterior body height in dorsal spine, and even in the lumbar spine, first there is an obliteration of lumbar lordosis and gradually appearance of a cervical kyphosis. Now, when neural deficit occur, when there is a pressure onto the spinal cord, in a cervical spine disease, it is a quadriplegia, all four limbs are paralyzed. However, in a dorsal and dorsal lumbar disease, it is the lower limb are paralyzed, lower limbs are loses power, and that's why it is called paraplegia. The constitutional symptom may be fever, weight loss, and night sweat. Now, when we examine these patients clinically, there is a tenderness you can elicit along the spine. There may be a deformity. If the deformity is very mild, just a prominent spinous process, it is called knuckle. Or when it is little more prominent, it is called angular. You could see here, this is the angular deformity. This is the just prominent spinous process, a knuckle deformity, an angular deformity, and severe deformity. You could see the rounded deformity and severe deformity. Now, one may palpate swelling which are fluctuant, suggestive of cold abscess. They are called cold abscess because there are not signs of inflammation as we get in a infections caused by the pyogenic bacteria. And rarely a spinal tumor syndrome where spine may not have these findings, but patient may have a neural deficit. So, on that basis, we are able to diagnose clinically a spinal tuberculosis. And that is why, and at this point of time, we suggest some x-rays, some investigation, and on the basis of clinical and x-ray, we call it pre-destructive when patient is just symptomatic and local tenderness, early destructive when there is a just mild kyphosis or a moderate kyphosis or a severe kyphosis, and that is how we classify the severity. As I said, this is the inflammation and that is how the disease occur. So if at this stage a plain x-ray is done, what we get is a regional osteopenia and slight reduction in the disc height, and you could see here this disc height is reduced. Now how do we call it on x-rays? Any disc height should be equal to the disc height above or more. Here this disc height is less than the disc height above. So now this is a suspected area, and now this kind of a suspicion on an x-rays, we can get investigations by MRI to diagnose inflammation onto the bone, which we will talk subsequently. Now in a classical case when kyphotic deformity has occurred, now you could see this is a classical kyphotic deformity. So there is a regional osteopenia, this all 3-4 vertebral bodies, they undergo osteoporosis, reduction and obliteration of disc spaces. Now here this is 3 vertebral body disease and there is not a single trace of disc spaces, while here you could see this disc height, disc space, the disc margin, they become fuzzy or obliterated. A kyphotic deformity occurs and a paravertebral shadow may be seen on an AP X-rays to diagnose classical TB spine on a plain X-rays. However, with further imaging, we can carry on and diagnose like bone scan, like CT scan and like MRI, we are able to predictably diagnose the disease. So thank you very much. I think today we stop here only. Excuse me.